Peter Kern. I'm the director of the Global Public Health Program, and the Global Health Program plus the External Advisory Committee for the Global Public Health Program is responsible for this lecture series. And we're excited about that. So I just have a couple of housekeeping announcements. If you're a student, I need you to sign in over here before you leave tonight. If you're a community member here for the first time, or even more than the first time, we'd like you to sign in as well. There's a sign-up sheet over there. There are evaluation forms there as well that we'd like everybody to take and fill out in terms of this particular meeting. One other announcement is that this presentation, as well as all the presentations in this lecture series, is being recorded by Missoula Community Access Television as part of their service to the community. So if you want to check that out, you can look it up at www.mcat.org, and that will get you access to this lecture and all the other lectures as well. Or tell your friends about them so you get a chance to come here tonight. Tonight we're very honored and privileged to have Jeremy Smith, the author of Epic Measures, here to talk about the true story of a 20-year, 500-scientist, $100 million moonshot attempt to track and quantify every illness, injury, and death for everyone on Earth. The biggest of big data ever. Bill Gates has said, Epic Measures is a fantastic read, and Publishers Weekly called it an inspirational tale for everyone. And the New York Times said the book was remarkably entertaining, a giant compilation of who knew. Epic Measures is also a Barnes & Noble editor's recommendation, one of iBook's best books for 2015, and an Amazon #1 bestseller. Jeremy writes regularly for the New York Times, The Atlantic, and Discover. And he and his work have been featured by CNN, NPR, and Wired, among many other outlets. His first book, Growing a Garden City, was one of Booklist's top 10 books on the environment for 2011. So how did we get him here? I think that's probably in everybody's mind. So here's the clincher. Born and raised in Evanston, Illinois, he is a graduate of Harvard College and the University of Montana, and he lives here in Missoula. So Jeremy is going to talk to us tonight about measuring global health. And please join me in welcoming Jeremy.
Thank you so much. I don't know if I killed my mic or if it's working, but I'm loud anyway. If I'm too loud or too soft, let me know. I'd love to, you want to tweak it? Yeah, please. No problem.
It's good with filming.
Of course. Okay. Stereo, wow. So I guess I want to just get a quick sense of the room first. Could you just raise your hand if you work in medicine? Okay. So actually a fair number of us. Maybe 1/5, 1/6. Could you raise your hand if you work in public health? Some way. Okay, wow. You want to watch out, medicine. Okay. We'll play flag football after. And could you raise your hand if you've ever volunteered in some way on a health project or a project that has some aspect of that? It could be clean water. It could be, something. Okay. But almost half of us, or half of us, I'd say. Could you raise your hand if you've ever donated money to a cause that has to do with health, like disaster relief, or okay, so over half of us. This is kind of funny, but yeah, could you raise your hand if you have ever had someone you cared about who was sick and you weren't sure that they would get the help that they needed? Okay, so that's about 90% of us. Thank you. That's really helpful to know just kind of where the knowledge is in the room and where the interests are. And I think that I'm going to share some stuff I think will be really relevant to you, I hope. So Epic Measures is a story, as you heard. It's got scenes, it's got characters, it's got action, it's got plot. It's awesome. I've got, out of the goodness of my heart, I've got some books here. If anybody wants to, browse it, buy it afterward, they're here. But I'm not going to tell you the story. I'm not going to get into that right now. I'm going to leave that to your future reading pleasure. Instead, I want to share some of the big ideas in the book and share some of the sort of findings that were surprising or striking or important or interesting to me. And I'm going to start with a really big look at the whole world picture, and by the end of the night, we're going to be all the way zoomed down here into Missoula. So let's get into it. Epic Measures, as you heard, is the story of the origins and impact of the Global Burden of Disease study, which is sort of trying to create the equivalent of Google Earth for Health, where you can survey an entire continent like Africa and see what's killing people and making them sick, or you can go zoom into an individual country like Angola or India or Italy or Canada or China or the United States. Or where you have more data, you can zoom down even further, down to a county level or even maybe a neighborhood level and see what's going on. And the reason we want that information is pretty simple. How do you help people? How do you save lives if you don't know what's killing them? How do you decide? Oh, are we trying to prevent drunk driving? Are we trying to prevent malaria? Are we trying to help people who are dying in childbirth? Or are we trying to help people who are falling in old age? Those are totally different kinds of interventions that you would be planning. So just like in medicine, we say, first diagnose, then prescribe. The idea is see what's going on, what's hurting people, and then try to help them. So great, but why would that cost $100 million? Why would that take 20 years? Why would that take, what is now close to 1,000 scientists in over 100 countries to put that information together? Aren't we already doing that? Aren't we already trying to solve the problems people have? And that's something I want to investigate with you in the course of our time together tonight. And I want to sort of do that through 3 questions I'm going to ask. And these questions are going to sort of explore what the world looks like in the absence of the information from the Global Burden of Disease study and what the picture we see with this new look. And I'm just going to give you a fair warning. The first 2 questions have kind of alarming answers. It could be a little depressing for some of the time. But the third one, I will get you to a happier place by the end. So don't worry. The warm fuzzies will come. So let's look at question number 1. What is the scientific evidence base for health policy? That is a fancy way of saying, what is the information we use to make our big decisions? How we spend our money, what we invest in, okay? What policies we're pursuing. What evidence or information are we using? And the answer is, in short, it's pretty thin when it comes to big picture health. Every year, this year, I'll just say, about 50 million people die around the world. Okay? So about 50 million people will die worldwide. Of those, only 1 in 3 will have a death certificate. So most people who die, there will not be a death certificate. So that's a problem because how do you save people's lives if you don't even know what they're dying from? In the absence of that information, different groups have popped up that tend to study one particular cause or place. So for example, in the absence of reliable death certificates around the world, you have UNAIDS measuring how many people are dying of AIDS. You have the Global Malaria Program measuring who's dying from malaria. UNICEF is watching out for the diseases that kill children just in case they screw it up. You've got Save the Children watching their back. Here in the United States, we've got the American Lung Association looking at lung diseases. We've got Mothers Against Drunk Driving, looking at drunk driving, for example. Of course, there's the famous pink ribbon for breast cancer. There's other less famous colored ribbons, like this purple ribbon for Alzheimer's awareness. And then you have sort of one-off campaigns in the aftermath of a natural disaster, like in the aftermath of the 2010 Haitian earthquake, the 2011 Japanese earthquake and tsunami, and just last year, the earthquake in Nepal. So this is wonderful. These are invaluable groups doing really important stuff, trying to save lives every day. But there's some problems with this landscape. Are these groups using comparable methods to measure? Are they using reliable methods to measure? Are they comparing their notes? If someone's going into these countries and getting the information, are they sharing notes with each other? Maybe, maybe not. Even bigger as an issue, though, is that all these groups have dual roles. They are measurers for their cause, but they are also advocates for their cause. They are trying to raise money and attention for the particular cause that they are studying. And when you have advocacy, if you have a range of numbers that you could choose from for how bad a problem is, you're pretty much, most of the time, most likely to say it's on the high end of things, because there's this kind of competition. If the things that kill the most people are thought to be the most important. And so you want your cause to appear most important, most dire, most pressing. And let me give you a specific example of this. In the 1980s, the international health community was focused almost exclusively on the health of children. Okay? This was the sort of Save the Children era. UNICEF was ascendant. And this is still the major focus of international health. And so you had different groups at the World Health Organization in Geneva measuring the leading killers of children. So you had a group studying children dying of diarrheal diseases, dying of pneumonia, dying of malaria, dying of measles. And each of these groups was in the same building, one big building in Geneva, but they were in separate offices and they were making separate estimates of these 4 different diseases. The scientists that later went on to found the Global Burden of Disease study did a very simple calculation. They added up those 4 estimates, A plus B plus C plus D. And when they added up those numbers, they found that the total sum was 10 million more than the number of children who die every year. Okay? The leading authority on global health had invented 10 million extra children who were dying. And it was worse than that, because children don't die from just 4 causes. Okay? They die from dozens of causes. Other major killers that were not being counted at all: congenital anomalies, cancers, birth trauma, fires, falls, drowning, car crashes. All of these have a big toll on kids in poor countries. And so you had massive overcounting on one hand, in a way that a 4th grader could understand, 10 million. And you had massive undercounting on the other hand. You had all these causes that just didn't happen to have a group measuring them, so they weren't on the map. And I want to give another example of that kind of issue. Another one of the scientists who later went on to co-found the Global Burden of Disease study got into it by studying tuberculosis. Tuberculosis, by his estimate in 1990, was killing about 2.5 million people a year. It was the leading infectious disease killer of adults. The AIDS of its time, the AIDS of our time, it's still killing a lot of people. And in fact, it combines horribly with AIDS to sort of stoke each other's cases. In 1990. There's an issue, though, with tuberculosis. The main people who die from TB are not children. They're adults in their 20s and 30s. These are important people. They're the parents of children. They're the bulwarks of the economies in their countries. They're the caretakers for the elderly. But because they weren't kids, and because the international community was only measuring kids, this 2.5 million people, the leading infectious disease killer of adults, was really not on the radar screen. There was one person working on it in the entire World Health Organization. I know we've got some people from Missoula County Public Health here tonight. I feel like don't we have like a quarter-time person in Missoula who does, TB stuff? I mean, it's just, like there's some TB presence here for Missoula. And there's not, there was one person at WHO. And I don't want to just pick on WHO. It certainly wasn't a unique issue there. The Institute of Medicine in Washington, D.C., which does big policy advice to US Congress, they had a ranking of diseases and causes that were the leading priority for health research. And they ranked them highest, medium, lowest. I would like you to guess, if you could, what ranking they put TB, the leading infectious disease killer of adults, the killer of 2.5 million people in poor countries a year. Lowest, I heard. So cynical. Not cynical enough. It was not ranked on their list. By comparison, leprosy was highest, was in the highest category. So just to give you a sense of blind spots. Now that same scientist who found that, sort of came to that estimate by putting together data from other sources, did an economic calculus too. The thing about TB is it can be fairly readily treated fairly inexpensively. And his calculation, kind of back of the envelope calculation in 1990, was it would cost about $700 million to treat all new cases of TB worldwide. By comparison, it would cost $4.1 billion to just deal with the fallout of not treating TB in the United States alone, for about 20,000 people with TB, most concentrated in like New York City and a couple other major urban areas. So $700 million to deal with this worldwide, $4.1 billion to deal with it just in the United States. Pretty compelling analysis, and people did listen. They acted, they reacted, to their credit. So to this global landscape was added TB, World TB Day, the Global Fund to fight AIDS, tuberculosis, and malaria. Billions of dollars flew, eventually, toward TB treatment, detection, and relief. The problem with doing things this way is you're always going to be a generation behind, though. And so let's stop picking on the 80s or the 90s. Let's talk about what's the situation right now in 2016 globally. Today, if you are in a developing country, poor country, you are most likely to die from a non-communicable disease, a so-called lifestyle disease. The same things that kill people in large numbers in the United States. Heart disease, stroke, cancer, diabetes, etc. Okay? In fact, 64% of deaths in developing countries are for non-communicable diseases. Okay? Almost 2/3 of deaths in poor countries are from those causes. Medical aid money is earmarked to particular causes. I would like you to guess what percentage of medical aid money goes to the killers of 2/3 of people in developing countries. 10%? 2%? Yeah, who knows? It's 1.2%. Okay, so by last count. So that doesn't say you should always exactly match your percentages. Maybe some things are cheaper to treat than others, or it takes a while to ramp things up. But that gives you a sense of the scale of the mismatch. Okay, 64% of killers get 1.2% of the funding today. So that's what is the scientific evidence base for health policy. Are we measuring the right thing? Question number 2. Well, we've been talking about death and killers. But is that even the right thing to be tracking? Seemingly so. If you want to save lives, you want to stop death, right? It seems pretty straightforward. But I kind of want to investigate that a little bit. So, for example, every year, This year, about 6 million people are going to die of stroke. By comparison, about 300,000 people are going to die of meningitis worldwide. So does that mean that stroke is 20 times more important than meningitis? It's 20 times worse than meningitis. Maybe, and maybe not. Something to know, I think, about those two diseases is that the average person who dies of a stroke is 70 years old or older. The average person who dies of meningitis is a child under the age of 5. So how do we think about that? How do we have numbers that sort of help us think about that? Sort of to answer that, you have this metric, years of life lost. Years of life lost is pretty simple. It says, how long do people live in the longest living countries in the world? Switzerland, Japan, something like that. It's about 85 years is the average life expectancy. And so, however, if you die prior to that age, you've lost that many years of potential life by that scale. So for example, if you have a stroke at the age of 75 and it's fatal, how far are you from that 85-year ideal? Yeah, that's 10 years of potential life lost. If you have meningitis and it's fatal and you die at the age of 5, how far are you from that 85-year ideal? 80, yeah. So by that metric, a case of stroke and a case of meningitis in those circumstances, the meningitis is 8 times worse than the stroke in terms of years of life lost. We're still missing something, though. We're actually still missing the greatest cause of pain and suffering. By far, the leading cause of medical spending. The sort of leading things that plague us and the people we love and increasingly plague people around the world. And that's everything that doesn't kill you, okay? If you're blind, if you're deaf, if you're anxious, if you're depressed, if you're disabled, if you're disfigured, if you're simply sick, none of those are causes of death. But they're all conditions which extract, quite a toll on you in your life. I want you to think about every time you go to the doctor and don't die afterwards, you're sort of showing what's missing, even with a perfect death record, a perfect years of life lost measure, okay? So how do we think about that stuff? Well, those same scientists introduced this other metric. Years lived with disability. This is a little harder to calculate, or a lot harder potentially, but in a nutshell, it says how bad is it to suffer these particular conditions based on polls of people around the world? And how long do people suffer them based on the epidemiological data they have? So how bad, severity times duration. So if you have a broken arm, that's pretty bad. If you have it for a week, you get over it though. If you have a broken arm and you have it for 20 years, that's another thing altogether. And if you're depressed for 20 years, if you're disabled in some other way for a long period of time, we want to be able to boil those together. So with these two metrics, we can sort of see things a little bit differently. In one, we have a sort of stand-in for quantity of life lost, those years of life lost thing. The other one is sort of quality of life lost in some measure. And because they both have the same unit of time, you can actually add them up and get total years of healthy life lost to any particular cause. Because this is big science, because it's peer-reviewed things, because it involves all these fancy grants, you have to have a terrible acronym for this. So instead of calling it total years of healthy life lost or healthies or something, human, they call it disability adjusted life years or DALYs. But all that means is total years of healthy life lost. And what does the world look like if we look at it that way? Well, let's look at the United States. Here's top 10 causes of death in 2010, according to the Global Burden of Disease Study. And here are the top 10 causes of DALYs. And just to sort of make clear the distinction between them, I want to put the differences in bold. So you'll see number 3 is low back pain. Number 5 is major depressive disorder. Number 6 is other kind of bone and joint pain. None of those conditions kill anyone at all. None of those are ultimate causes of death. Okay? But they affect tens of millions of Americans quite severely for decades at a time. And so their toll is quite large with this way of looking at health. Go to number 9, road injury. That's an interesting one because road injury does kill a large number of people. And something important about it is that it kills them not at late ages like some of these other diseases, but it kills them, the most frequent people to die from road injury are in their teens, 20s, and 30s. Okay? That's why your car insurance is, you can't rent a car until you're 25, things like that. They're looking at the numbers. The other thing with road injuries, though, isn't just that it kills people at early ages. It's that many people, however many people die of road injury, lots more people just get in accidents. And those accidents give them severe head injuries. They are disabling. They are disfiguring. They break their arms. They have these conditions they may live with for a lifetime afterward, for decades after. And so it has a big toll on both sides of the equation. The last one I want to just sort of look at quickly today is just neck pain. Okay? That's number 11. And this is something that's like, it's just so, it's like proverbially dismissed, right? It's literally a pain in the neck. But by their tally, this particular ailment has like twice the toll of breast cancer in the United States. It's worse even for women, okay, neck pain. And I say that with no particular glee. My grandmother, one of my grandmothers died of breast cancer. My mother is a breast cancer survivor. But gosh, there are so many things, with the, pink ribbon. There's walks and products and campaigns and fundraising. And I've never heard of a ribbon for neck pain. I've never heard of a walk for neck pain. I've never heard of a celebrity spokesperson for neck pain. The NFL dresses up in pink for a week. They put all the football players in pink for breast cancer for a week. Even the NFL doesn't care about neck pain, right? So it's just this amazing kind of mismatch if you buy into that kind of stat. So just sort of interesting to think about, and if you have these conditions or you know people with them, maybe they start to make sense, and you're like, that does resonate for me. And frankly, it'd be pretty shocking if you didn't know someone with some of these conditions, because that's why they're so high on the list. So let's go to the third question. I think we're ready, right? So what if we do buy into this stuff? What if we try to use the best possible information, and let's say we buy into these measures that sort of look at the hall of health, not just death? How far and how fast can we improve? A couple quick examples. Mexico, one of the earliest adopters of this burden of disease approach, saw the first global burden of disease study, said, the Minister of Health said, I want this for Mexico. Can you come to Mexico, train my people, and we'll do it so we can zoom all the way into our provinces, our cities, our people. And they did it. And they found a situation a lot like what I showed you with the World Health situation, where their health system was built for the health situation in Mexico of the 1950s, when women were having 6, 7, 8, 9 kids. A lot of them were dying in childbirth. You had a lot of preventable childhood diseases and a lot of people dying of infectious diseases. By 2000, women in Mexico were having about the same number of kids per couple as in the United States, right around 2. Heart disease was the leading killer. Diabetes was about to reach epidemic proportions. And you had car crashes. You had, depression, back pain, all these other sort of causes that I've stepped through for the United States. And you also had a situation just like in the United States, where 50 million people did not have access, were basically excluded from the health system because they were unemployed or self-employed or out of the labor market. So you had a health system that was totally mismatched to the problems most people had, and you had lots of people that weren't having access even to that mismatched health system. Seeing evidence on that scale drove really significant reforms The health minister proposed, the president seconded, and the Congress passed comprehensive health reform, where they tried to offer a public health insurance package that matched to the covered people's problems to sort of in the order in which they had them, the sort of order of burden of disease, sort of had the earliest and most comprehensive coverage for those things that were taking the greatest toll, and really retrained their medical system, their staffing, their pipeline, and sort of where they were directing their resources. And had quite dramatic changes in a short period of time. In less than 10-year period, they went from the situation I described to having a form of universal health care. So to me, this was a surprise. To me, this was news, at least when I was reporting this book. I couldn't believe I hadn't heard this before. There is a country in North America that has achieved a form of universal health care in the last 10 years. That country is Mexico. Totally different example, Australia, second early adopter of the burden of disease approach. Australia already had a universal health care system and a pretty wealthy country, much wealthier than Mexico. But universal health care isn't magic. Someone's still paying for it. It's not just, you can't just do anything for anyone all the time, and you also don't know what problems to treat people with unless you allocate your resources wisely. And so what they said is, can we use this information, especially to direct our public health spending, our preventative efforts, to try to prevent the things that we're seeing people having in the places where they're having them? And a couple generations ago, so there's like 200 countries in the world. About 40 of those are wealthy countries. And a couple generations ago, the US and Australia, in terms of life expectancy, were right in the middle of that pack. So they were both around 20th. Australia, made these aggressive efforts to sort of target the problems they had preventively, if possible, through public health efforts, and has seen really dramatic advances and continuing advances. Today, male life expectancy in Australia is number 1 or number 2 in the world. If you are a little boy born today in Australia, you are likely to live longer than a little boy born in Japan. Women are about 5th or 6th. And in the United States, meanwhile, in that sort of generation that has passed since then, we're now pretty much at the bottom of the pack for those. We're around 40th among wealthy countries. So you can have 2 countries that start at a similar point and go in really different directions by the sort of decisions they make, in part. And I don't want to say everything's horrible in the United States. There's wonderful health care in the United States. There's wonderful health outcomes in the United States in certain places. And there's big gains. So here, for example, is New York City. Here's a chart of changes in life expectancy. If you're a kid born today in New York City, you are likely to live 10 years longer than you would have a generation ago. Okay? If every county in the United States had the same gains as New York City, we would be the longest living country in the world by far. Not 40th, but first. And they did all these crazy things, right? They had early and aggressive detection and treatment of AIDS, then TB. Then they had this insane nanny state mayor who told them that you shouldn't be allowed to smoke inside, and then you can't even smoke outside. And then it was like sodas, and now they've got a new insane nanny state mayor who wants to zero out traffic deaths. But the thing about these insane people is that sometimes what's insane a few years later becomes totally normal. When I moved to Montana, which wasn't so very long ago, it was legal to drink and drive. The driver could be drinking, okay? You just could not be drunk. So now you can't even smoke, in Charlie B's. So these things that are just sort of unimaginable become just the boring, normal status quo. And that's true in like Russia, you can't smoke, I'm told. So it's fascinating. And so just don't be trapped in the sense of like where we are is where we'll always be and everything's horrible. So let's look at the United States. Here's a map. And this is all publicly available. This is all online. You could do it on your phones right now, but maybe don't for the second. But do, I don't care. Healthdata.org, US health map. Here's a map of US counties, but color-coded by life expectancy for women. And the just thing I want to flag is that if you live in a dark blue place, you're a woman, you're living like you live in Switzerland or Japan or longer. You've got great health outcomes. Tens of millions of Americans living better or as well as best countries in the world. If you've got dark red or orange, you're living in like Syria or Panama or parts of sub-Saharan Africa in the worst cases. So we have wonderful health and we have terrible health, in this country. And now we can start to see where and maybe why. I want to flag one more thing here. This is change in life expectancy for women. And I want to just flag the places in red, in dark red. That's a third of US counties. Those are places where female life expectancy has actually declined in the last generation. This is a place where if you're a little girl born in these places today, you are likely to live less long than your mother. And that's the first time that's been true in US history in the absence of accompanying a war or infectious disease epidemic. Okay? So there's something pretty bad going on in those places. And we should think about why. But let's look inward for a minute. So what happens when we zoom into Missoula County? Well, it's easy, right? We often have this sort of assumption that we know why those colors are colored the way they are. If you're rich, you live a long time. If you're poor, you die. And there's a fair amount of truth to that. Probably income is, a leading determinant of health. Age is probably even more of a determinant. But is it all that's going on? Maybe, maybe not. Let's look at that. So Missoula County, in terms of poverty, is in the middle 50%, right at the US average for poverty. So if that's the case, and if income and wealth is the sole driver of outcomes, then we would expect our life expectancy to be right at that 50%. And maybe it is. But let's look under the hood at a few other things that are going on that might also influence our health. Smoking. Are we big smokers, little smokers in between? We're in the best, according to the data, last time I looked it up, in the best 10% of all counties for men. The best
of all U.S. counties.
U.S. counties. Best 25% for women. Okay? So, okay, doing okay, not great, but good for men and okay for women. Obesity, leading driver of a lot of today's leading killers and causes of illness. We're doing well on average for the United States, but still in the best 10% of all counties for men and women. Physical activity. Are we skiing? Are we ice skating? Or what are we doing? Okay, we're actually doing pretty good in the best 10% of all counties for men and women on average. So it's great. We live in a wonderland. Everything's perfect. If women just smoked a little less. Uh-oh, I forgot that was going to be up there. So prevalence of heavy drinking. We're in the worst 10%, last time I checked, of all US counties for women. And we're in the worst 25% for men. And I want to be clear, that doesn't mean that women are drinking more than men, because men drink more. So this just means, we're just a real gender parity place where women here drink as poorly as men. And then there's binge drinking, which is really important because we think of drinking causes in a night like liver damage or something. But it also causes car crashes. And it's a leading contributor to intimate partner violence and falling and drowning and having all sorts of kind of accidents and fires and suicide and all sorts of other things. So it's one we want to flag. And again, we're in the worst 10% for women and the worst 25% for men. So how's it going to shake out? Is our exercise going to beat out our binge drinking? Or, well, we'll look at it in a second. But it's just, I want to say whatever it is, it's important to sort of see as much of what's going on under the hood as possible. Because Otherwise, we just get results and we don't know why they are, and we don't have a sense of how we might change them. We might be doing well, and we might not even know what we're doing well, and we might stop doing it. And we might be doing something poorly that wasn't on our map before, like TB or some of these other things I was mentioning. Anyway, what does it shake out? Best 25%. Okay. So better, we're punching above our income level, and maybe it's some of that exercise and smoking, and we can keep pushing it down. Maybe if we work on some of those other things that we aren't doing as well. And the other cool thing with this map is here over on the top, here's all counties in Montana. Missoula is highlighted, but you can see there's 7 or 8 that are poking above us. Is it because they're horrible, rich, arrogant, spoiled, pampered people in Bozeman? Maybe. It wouldn't surprise me if Gallatin County is up there. But there's some other places too. What are they doing? Are there places at our income level with some of our demographic similarities that are doing better than us? What's under their hood? What tricks might we learn from them? And then there's a lot of, there's some places that are dramatically lower. And what's going on there? Is poverty much worse? Are some of these other things much worse? I don't know. But now once we can see it, these sort of questions demand to be asked. And we can say, I don't want to live in Switzerland when, 15 miles away. I don't want to live in Syria where 15 miles away is Switzerland in terms of health. I want to live in this place, and I can see why. Or how can we improve? What can we look at? And take a look. And so that's exciting to me. And this is all public. It's live. It's interactive. I'll show you the links in later. Or we can play with it at Q&A. And just big picture, I'm excited. We're going from, this tool is also there. This is where I got that top 10 list for DALYs and death in the United States. It's full. It's the United States, and I could flip it from DALYs to just years that live with disability. I could see what are the leading causes. Or I could just say, I don't buy any of those new metrics. I just want to know what killers are. But I don't want to miss any of them. And I could just do it to deaths. Or I could say, you know what? I really care more about, a group that's really important to me personally is men between the age of 35 and 39. Okay, I hope you all focus all of your efforts on helping men between the age of 35 and 39. They're really important to me. I think of them every time I look in the mirror. But I got a daughter who's 5, right? I've got a niece who's 22. I've got a wife who's has no age. You can play with it and zoom in. Or I've got friends in Ireland. Or I'm going to visit South Africa. What's going on there? And I can flip it and move around and look. And it's live and it's constantly updated, and anyone can do this. And we're going from this sort of picture of the world. And I think of it, and I talk about this in the book, it's sort of like the map of the world in like 1490, where you just didn't have a sense of, you knew there were other places out there, but you didn't know where all the continents were. And you didn't know how big they were relative to each other. And you didn't know necessarily how to get from one to the other. And you had sort of whispers and rumors from spies and courtiers and traders. But that was sort of the state of our sense of the world. And we've been filling that map in little by little over time. And as opposed to this picture, there's this picture. This is a map of global DALYs in 2010. In blue are causes that are non-communicable diseases, chronic diseases, so-called lifestyle diseases. In red are infectious diseases and problems of childbirth and nutrition, sort of what was traditionally thought of as the causes of global health. In green are injuries. The bigger the box, the higher the percentage of the problem, the toll is from that particular problem. The darker the box, the greater it has increased in severity in the last 5 years. And if you put your mouse over them when you do it, it shows you, like IHD stands for ischemic heart disease. MDD is major depressive disorder. It's not LRI, TB is TB, LRI is lower respiratory infection, it's pneumonia. It's not all crazy acronyms. And what I love about this map It's all still, it's the 1500 map. It's not the, it's not Google Maps quite yet. It's rough around the edges, but you have measles, but you also have TB. You have breast cancer, but you also have neck pain. Okay? You have natural disasters, but you also have suicide, road injuries, and other kind of causes. And you can sort of look, and again, you can divvy this up and change it by country or cause or whatever you want. And it's just a way to sort of see things together, get a big picture for the first time. You can play with these tools. They're all at healthdata.org. You can learn more about the book by buying it and reading it, but also by going to my website, jeremynsmith.com. I'd love to just hear from you about your experiences, answer any questions, sort of talk more as long as you'd like. Thank you so much. How does it work? Do they ask questions? Do they just get to run away? Do they want to do anything? Okay, yeah.
I have a question about how much of the data we can really count on given estimates. For
Yeah.
example, there are countries in the world like Somalia where there aren't people actually doing censuses and things like that. So obviously this is a big improvement, but how reliable do you think the data is on things like violence, for example?
Yeah, so if I've just been talking about how we don't have death certificates, how on earth do we know what we're talking about? So that's a lot of the story of the book. And you've got this sort of, it's almost like a caper where you bring in all these different people with different talents around the world to try to fill in those gaps. So you have people visiting cemeteries, police stations, census records. You have this thing called verbal autopsies, where people go door to door in sort of village settings and do interviews with the recent people who are relatives of recently deceased people. You have a giant supercomputer cluster at the University of Washington where this study is based that's bigger than their genomics supercomputer, one of the biggest sort of computer setups in the world, that is trying to crunch all these numbers and make the best estimates possible. And you have a lot of, frankly, for lack of a better word, fancy math and computer science people on board, that what they try to do is model these and then test their models with places where they do have good data and have a sense of how reliable their models are. But the other thing they do is for all their estimates, they give you a range. I think maybe I showed it in one of these. Let's see if I go back. They give you these uncertainty intervals. And this is in percentages are a sort of funny thing to have uncertainty intervals for, but they say, we believe that 45% our estimate is that 45% of people in Angola suffer from low back pain. And behind that, what we mean is we believe that between 30 and 60%, they'll give you a range. And that range they're saying with great confidence based on their best available data. Or they might say, we believe that 45% have low back pain, and we think we're saying that with a confidence of between 44 and 46%. We're quite confident. So it depends on the setting. So if it's going to be low back pain in Angola, it's probably going to be a bigger range. If it's AIDS in South Africa, it's probably going to be a pretty tight range. It's going to be something that's pretty well tracked. And so on with different forms of disability. And that's also useful as a prod to further research, because you can say, what are the things that have the biggest intervals where the guesses are wider? And that says this is where we really need to go in and get more data. But I tell a story in the book where they basically had, it was almost like a spy caper where they got like a rumor that there was like an unofficial census in Iraq during the US occupation. And this had been smuggled into the green zone. And they were like, can we get this so we can add it? It's like 1 million data sources. Can we add this to our database? And they were like, yeah, you can use it. They're like, great, here's our email address. They're like, we're not going to email it to you. They're like, well, here's the mail. Can you mail it? They're like, we're not going to mail it to you. So they had to send someone to the green zone in Baghdad, to get that one data point. And they're using like 1 million of these. So it's this super aggressive trying to bring those things together. As countries start wanting to use this data and seeing things like what Mexico did, Australia did, lots of other examples from Rwanda to Vietnam, and I could go on, they're also feeding them their data, so then they process it, and then they can use the results. So they now have it at like a provincial level or a county level for like China, Mexico, the United Kingdom, for example, Saudi Arabia. Yeah.
Okay, so knowing what you know about single-payer healthcare systems in Canada and now Mexico, kind of puts the U.S. in a funny position of being sandwiched between these two countries that are doing healthcare fairly well. What is your reaction, like, after your research to things like the Affordable Care Act, but then also people being upset about the Affordable Care Act?
Yeah, I mean, I try to be a reporter. And there are these giant stories, they're just new ways of thinking about things that I'm trying to share. And, take it as you will. I don't even think of the US as being sandwiched like between Canada and Mexico. I think if there's 40 wealthy countries in the world, and there's only one that doesn't have that system, and it's the United States, a form of that system, and the United States has the worst health outcomes, and of those 40 countries, there's one that has the most healthcare spending per capita, and the United States is first in that. So we're first in spending per person, and we're last in that kind of outcome, and that, I think, would really push people to explore other systems. Some of the Mexicans were telling me, they were like, yeah, Obama stole all our ideas. Roll it in, cover people, get them there, have these sort of penalties, cover the things that they're having. It shouldn't be a radical approach. Try to provide care for the problems people have in the order in which they have them. But that can be radical, and it does obviously threaten a lot of entrenched interests. U.S. healthcare system is very responsive if you do have money. It will respond to your condition with great alacrity. So that's an advantage of the U.S. health system. And I don't have a ton of other great things to say about the U.S. health system. But, and I want to make clear, there's the medical health system, and then there's the public health system. One is more preventative, ideally. Instead of dealing with a patient at a time in a reactive way after they have an issue, it's like, how do we get people to reduce smoking or car crashes or a bunch of things that can save millions of lives without requiring medical school at all, or even ideally you never know that you would have been sick. And so the U.S. is really variegated by county to see sort of what measures they do. In some places you have really aggressive measures that have been very successful. In other places, sex ed is basically illegal. It'd be interesting to look at that map and see if there's some common policy things that make people in those dark blue really healthy places versus dark red and less healthy. You had your hand up first, ma'am.
Oh, I just looked at those maps before, and if you cross-sector them with the wealth of that county,
Yeah,
you have your poorest counties that are in the red.
Yeah.
And you have your richest counties in the blue.
yeah.
So it's pretty obvious, but not entirely, because I looked at those yesterday.
Yeah, I mean, like the Missoula example,
Appalachia, for example, in the south is like, they're so poor. And Gallatin County is the richest county in Montana, and they're one of the healthiest, so.
well, Missoula's right at the average, and we're also one of the healthiest. New York City is also a 50th, like the Bronx. Yeah, so, and the Bronx, in New York is in like the bottom 25%, is poorer than Missoula, per capita, has better health outcomes. So I think you're absolutely right that if you're going blind, that's, if you're rich, it's going to be a lot more likely to have good health outcomes. And if you're poor, it's more, but it's not the only and not even necessarily the leading determinant. I would argue some of these things. Appalachia and the South also have very high smoking rates.
Well, and you also have to think about how things are funded and whether it's tax-based or not.
Yeah.
Right? So a lot of Missoula is funded by property taxes right now because we don't have a sales tax, for example. So if you were really to take the economics of a community and break it down by who pays for what for that community, I think that paints another picture.
Yeah. Well, what's cool is like you can have this claim And then you can go dig in and see, is it borne out? And is it borne out, I mean, the United States is one of the wealthiest countries per capita in the world. So that would suggest we should have the top health outcome. But it's obviously super spread out in sort of where the wealth is. Chris, did you have a question?
So have you observed any interactive effects between neighboring countries? So I'm thinking of if you have a area crisis like in Africa or Asia, and if you know that one country changes its health system dramatically in this way, that it'll have a spin-off effect on neighbors. It gives you a strategy to try to approach a region. But would the data bear that out? Is there any kind of interactive?
Yeah, I mean, I talk about this in the book, too, about health system evaluation, which is really hard because diseases and even medical practices are, cancer is cancer across one country to another. And to some degree, cancer treatment is. But the health system, even in Canada and Mexico, is completely different. In Canada, Mexico and Colombia is completely different. Germany and France and England, even Australia and New Zealand, have these big differences. So they're trying to get to that point of, can we evaluate health systems in the same way? And can we learn things? I tell a story in the book. They did a ranking of health system performance, which was not just how healthy are the people in this country, but at what's the cost that you're spending to achieve that level of health, and also how many people are excluded from care, how many people are medically impoverished. Boiling all those together, the country of Oman scored very high, actually. They were like number 6 on their ranking. This was the infamous thing where the US was like 33rd or something in the world, and it's often cited, 37th. And the country of Yemen is right next door to Oman. And they saw that, and instead of taking this as sort of, they're the winners, we're the losers of this ranking, they thought, what can we learn from our neighbor? And they've been sending people for the last 10 years on sort of fact-finding missions to Oman and sort of medical cultural exchange. And they found that they had this sort of ambulance system set up that was much more efficient. It was like centrally located to get to people faster, and they modeled their thing after that. They also found, just something that's really common is health systems where you have places where the hospitals are constantly slammed and the clinics are constantly slammed, and others where they're dead a lot of the time. It's not a very efficient setup because it's a state model or it's set up 50 years ago. And they shifted their staffing and their sort of their institutional footprint. Again, just sort of meet people where they are. That seems obvious in retrospect, but those are a couple examples of things they did at the time that try to learn, which is, hopefully that's the pride. Hopefully if you're in one of those other places, you say, hey, I'm in the same country as this person, or I'm in the same region as this person, I'm in the same economic level as this person. I should be able to get the same, if I just look at my economic peers, can I get the same outcomes they do?
Yeah. Just in terms of cost benefit analysis, you've already shown that the cost of prevention is much less than the cost of treatment, but you seem to pursue this on a state-by-state basis. And insofar as it goes, you mentioned that certain states have done certain things to their health systems to make them more effective in cost versus benefit. Do you think that there might be a larger cost versus benefit if we view health as a global issue and we do cost benefit analysis on a global level instead of state by state? Or is there any tangible benefit or cost?
Yeah, like the TB example was a global example. And when we deal with infectious diseases, we do that because we're freaked out that someone from this poor sick country will get on, can get on an airplane and infect us. If I want to say it cynically or just to say it nobly, we live in a connected global world, and we recognize that disease trends spread. What hasn't really sunk in, at least at a policy level, and I would say even to me it was total news, is that these lifestyle diseases, if you will, have also spread globally with globalization. And when you have children being vaccinated and they're not dying before the age of 5, in these huge instead of having 20 million children dying that way, you have 5, 6 million, which is obviously 5, 6 million too many, but the way I kind of think of it is like there's this sort of idea that if you save this child's life, they'll like magically live to be like an 85-year-old Norwegian. And it's not the case. If you save someone's life, they can then die of something else a little bit down the road. So you can't just save their life, or you can't just have this sort of one cause we're going to do and then we're done. If you save this kid's life, then you then got it from this vaccine preventable disease, then you got to make sure they don't die of a car accident in their teenage years, or violence in their 20s, or suicide, or ovarian cancer in their 30s, or heart attack in their 40s, or diabetes in their 50s. And those are all coming pretty hard at them pretty fast because there's not an awareness, there's no detection, there's no treatment, there's no money going to those particular causes often. And so we see huge increases in child survival rates, and then they kind of hit a wall where these other forces mow them down. And so I think that the global health community and the global community can really rally at a global level to sort of hopefully come to common cause. It's hard though, right? Like you've seen a big-eyed kid on a brochure, and it's just more compelling than me going like this. But hopefully we can find solidarity with each other and just sort of realize we're not alone in dealing with these conditions, and we can really improve people's life. If that's what we really want to do, there are these other opportunities.
Well, since we're doing big thinking tonight, do you have any ideas of how we can channel some of the funds into these lifestyle choices to affect the Dallies?
What do you guys think? I want to hear somebody else's ideas. I don't have a better idea than anybody else.
I think that just thinking about things like lower back pain versus like the prevalence of certain cancers, I would think that a lower back pain or a neck pain would be related perhaps to like a sedentary lifestyle trend that a lot of us are trending towards. Like sitting all day is obviously not great for your back, where I would think that prevalences of cancers would be more likely of like nasty chemicals in our water and our food and our like general daily items. And so I would say like if you're looking kind of on a big picture scale of where you can put your money or where our government could put our money or taxes could go, I think you would have to look at like preventative lifestyle changes of being active, and then also like massive regulations of our chemicals, because if you look at the regulation of our chemicals in this country, it's so poor compared to regulations in Europe. And I think that would be my thought on how to fix some of those more lifestyle diseases of more like just activity and regulation.
Yeah, I think of, in part just talking about it, it's funny to say just talk, but there is a stigma to a lot of these things. They're dismissed. And this is true of depression, anxiety, and, honestly, neck pain we talked about, back pain, even just the idea that you're not alone and you're not a spoiled brat, and that this would be true if you were in, almost anywhere around the world. And I think that's just a start. And I take inspiration from other examples. I mean, AIDS is, probably the top cause of global health, sort of funding and attention for the last decade, other than child survival. And AIDS, a decade before that, was hugely stigmatized. It was, gay-related immune deficiency in the United States. You had this middle school student, kicked out of school, getting AIDS from a blood transfusion. It was this othered disease, and it was highly stigmatized to go from, and it was just sort of disgusted and moral reproach, to the sort of noblest and highest and naturalist cause. Again, it was like the smoking thing. It was like 10 years later that just somehow had happened. And it didn't just somehow happen. That's part of the story in the book and in other books. But these big changes in sort of what we view as important or noble or necessary can happen. Well, yeah, first.
So this study changed the way we looked at diseases and things that we say will kill us, but looking forward, what do you think the next step in measuring health is going to be? Do you think we talked a little bit about combining common causes for the different diseases that, like obesity, can cause COPD or ischemic heart disease? What do you see as the next big jump that would be the equivalent of the GDP.
Well, you know, it's funny, right? Like, of all the innovations, of all the fancy math, of all the hundreds of millions of dollars, the biggest innovation is like double entry bookkeeping for death, right? It's like saying like, no, if you just say like, of all the things people die from, they have to add up to the total number of people who die. Like, and they're never going to have a bigger innovation than that. And then, you know, the second thing is to say, oh, we got to measure this disability stuff too, these things that don't kill us. And then we've got this 64% to like 1.2%. And we have that repeated often. You know, you often just find that you're putting 90% of your resources into like 10% of your problem. And half your problem you weren't even aware existed when you look at this data at a US level, at a county level, at an international level. And I think that they would love to, and they're racing to fill in this math and to do more cross things so you can look at economic determinants. They did a big study of like, what's more important, like getting wealthier or getting more educated at a country level? And I tell that story in the book. And it's not the one I would have guessed, I'll put it that way. It's not even close which one is more beneficial for health. And, you know, but just sort of, even if we start with where we are, I mean, yeah, you can get, Google Earth is great if I want to like look at my windowsill, but I could still take like a 1950s highway map and like get from here to Los Angeles. And maybe that's a good start to mix metaphors. Let me take like two more, and then I'm happy to just talk one-on-one. I don't mean to detain people, and if you guys want to browse or books too, happy. The two of you, yes, ma'am, first.
With the explosion of neuroscience and the impact of toxic stress on children, the ACE study and all of that, it's such a predictor for some of these preventable and chronic illnesses. Are they touch pointing that at all as we start to have more data about communities and ACE scores? Maybe that's something that we can look at in the public health sector.
Yeah, I should have flipped this. So you'll see that highlighted in green is causes. You can flick that to risks. And what that tries to look at is some of these determinants of health, which might be environmental, to sort of, you know, go to Eliza's point, or it might be workplace, it might be tobacco or alcohol, it could be indoor air pollution, outdoor air pollution, and it can be, you know, and trying to add things like what's the correlation between education level, or how much of child abuse is driven by alcohol consumption, how much of suicide, you know, and they're doing their best estimates of these things. It's a high bar. It's sim world, right? And they try to only give estimates where they can do them with confidence. So there are things that they don't provide estimates for because they don't believe they can do that with any range of confidence. But that's what they're pushing to do, and they're quite innovative, and that's their specialty, is to try to bring in, you know, these people from around the world, leading lights, you know, in trying to make those kind of modeling and connection. The kind of people, the sort of push they said is, you know, you can go to Google or Goldman Sachs and, you know, make $1 million bucks. You can come here and you can influence 1 million lives, and that's sort of the trying to draw those sort of big math and computer science kind of minds that can help do some of that kind of modeling.
Yeah. So I'd like to come back to the what can we do question for a minute. And it seems to me that part of the answer to that question is not just approaching each of these different disabilities and life-changing events, but also raising additional funding. So you used the example of the World Health Organization only having one expert on tuberculosis. They didn't have anybody for Ebola. And part of the reason for that is because they're so underfunded. And what a lot of the resources in the public health area or global health area go into is the work that's being done by NGOs and by philanthropists. And those tend to be single disease kinds of focused efforts. And whereas if you were to raise money on a more generic scale, like for example, in a government sense, or for money for the World Health Organization, you might be able to approach things in a more multi-analysis kind of framework. So one of the things, I'm leading up to a question. The question is, wouldn't it be interesting if you could, in your data analysis, plug in some financial information as well and address all of these things with where is the funding going and what rank does funding have for, let's say, low back pain versus other kinds of things?
We'll have great news. It's on there. If you go there, there's the Financing Global Health tool. It's a visualization, and you can see by cause, you see where the money comes from and where it goes. And you can look at it by cause or country, and it's really illuminating to see. I mean, that's where I got those stats on, the 64%, 1.2%. And it's a cool interactive chart because you can sort of flip it and see where it's changed over the years and see where like Bill Gates comes in, and you can see where the US government's commitments have really increased or decreased. Global health spending has increased dramatically. It's quintupled. It's over $30 billion a year. That's still arguably a pittance. Like the VA system in the United States spends like $60 billion a year to cover, a few million American veterans versus half that amount to cover 7 billion people in the world. At the same time, if you're lost and you're trying to get somewhere and you're lost, if you just go faster, you're not going to get there sooner. Like you also have to stop and consult the map. So this is sort of the story of the making of the map. And so hopefully you can use the money you have more effectively, but then also, and that has an additional benefit of then saying, look, I used the money I had more effectively, give me more money. And I can do that much more. It's not just a money pit. So yeah, let's just talk.
Well,
Come, hang out. Yeah.
let's give Jeremy another